Hi everyone, welcome to Research MD. We got our regular morning report case and we're going to discuss a case. Let's start. You guys ready? Okay. So what do we have today? Somebody tell me.
We have a 65-year-old female who presented to the emergency room for evaluation of diarrhea.
65-year-old female.
Presented to the emergency room.
Diarrhea. Big topic, right? So we got diarrhea as the presenting complaint. So somebody tell me first, we need to know what is the definition of diarrhea?
Increase in frequency of stools.
Increased frequency of stool. Is that a good definition?
2 to 3 stools.
Yeah, always express in numbers. Remember, if you cannot express in numbers, you don't know the situation very well. That's always my thoughts. So everything I do, I try to express in numbers. So the loose stools greater than what? 3. Okay, loose stools greater than 3 for 24 hours, you can say diarrhea. Or like, some books have like a definition, like some organization is like 200 gram per 24 hours of stool. I don't know who's going to measure all this. 200 ml greater than 24 hours. Those are the other definition. But I will usually, if somebody asks you, let's say 3 stools, more than 3 stools per 24 hours, okay? So everybody knows that. Now, what is the next thing we have to do is, we need to know, look and see, how do you classify diarrhea? What is the classification? Somebody tell me.
Acute and chronic.
Okay. Is there something in between?
Persistent.
Acute, persistent, and chronic diarrhea. 3 things. Okay. Somebody tell me what is again numbers. Acute diarrhea. What is the definition?
Less than 2 weeks or 14
Yep,
days.
14 days, 2 weeks. Number. I like 14 days. Remember, less than 14 weeks acute diarrhea. What about persistent?
2 to 4 weeks in between.
Yeah, like 14 to 30. Let's say like 14 to 30 is persistent. Greater than 30, we can say like chronic diarrhea. Okay, remember that. Acute, persistent, and chronic diarrhea. Those are the ways. So tell me about this. Let's hear about this diarrhea. So you need to tell me a little bit more about the diarrhea. So tell me a little bit about this diarrhea.
So this patient was in a normal state until he had right-sided abdominal pain with loose bowel movements.
Okay.
And that happened after he had food at a new restaurant this weekend.
So he ate some food at the restaurant and over the weekend. Okay. And then what happened? He started having symptoms.
Yes.
How long after? Do we know that? Okay. Do we need to know what he ate in the restaurant?
Yes.
Right? So when you take a history, like the rule is like we need to go and find out, did he take seafood, those kind of things, because it make a huge impact in the diagnosis, right? Patient could die because we don't take a good history. So make sure when you take the history, like if you have gone to restaurant, what exactly did he eat, right? We also there's some of this are kind of reportable also to the government. It's like food poisoning. They usually come and check it out. It's hepatitis outbreak and all that. So when you take a history, it's very important, okay? So the only thing we know is, so let's start with this. An acute diarrhea or chronic diarrhea?
Acute.
Acute diarrhea. Let's look at some of the definitions. So some of the differential diagnosis, let's say acute diarrhea, right? So everybody agreed that here like acute diarrhea. Only thing we know, he ate some food from the restaurant. But let's talk generally, like what are the differential diagnoses of diarrhea? Okay, when somebody comes with the diarrhea, the first thing I do is it really diarrhea? That's my question. Okay, so what are the conditions? Cannot be, it's not usually diarrhea. Okay, what are they?
Fecal impaction.
Fecal impaction, right? If you have fecal impaction, and that can also the stool kind of can leak around the area and then can cause what else? What are the other things?
Incontinence.
Huh? Incontinence, okay, especially like elderly people. Are they going to say I got incontinence? Everybody's kind of trying to cover it up, right? They don't want to say. So what are they going to say? I got diarrhea. So when you have an elderly patient, so it's good to know what the history. You got a good relationship with the patient, they will tell you what's going on. Okay, that's the first thing I do. I will rule out incontinence. Okay, then I will rule out fecal impaction. I'll ask about the constipation history. Everybody okay with that? And the next thing I look at the medications. Okay. So what medications are common can cause diarrhea? What medications?
Laxative.
Laxative.
Laxative. You can't. I cannot tell you how many times I have, doing rounds and I find out, patient come with the diarrhea. You order all these tests. What is the first thing they order? Like C-diff test, all the other things to find out what's going on. And then I go to the medication list. Then I can see he's taken diarrhea. He's taken like laxatives or any other medications kind of related to that, right? Magnesium containing. So let's say laxative. What else?
Antibiotic.
Antibiotic, like, is very common, right? Anything. So you have to, what's the first thing you have to do is, like, again, remember we talk about good history, right? Going back, use to establish the temporal relationship, what happened, which you did a good job. I'm not saying that. You did establish a temporal relationship. You go to the food restaurant and then you come back, right? At the same time, you have to look and see if there are like some medication starting, right? This could be like antacid you have taken, magnesium containing supplement, if they have something like, SSRI is like, yeah, very good. SSRI could cause. What else could cause? PPI itself can cause. Metformin, right? If the patient is on metformin, that's like the classic one of the question that can cause diarrhea. Okay, and if PPI, we already said, like antibiotic, any magnesium containing. So we'll say antibiotics, right? Magnesium containing compounds, right? We say metformin because most people who have diabetes is on this drug. We talk about SSRI also, right? Any other drug doing anything else? NSAID also can cause. So many things can cause, many of this medication cause diarrhea. Okay, so the first thing always, let's go back, what do? Rule out is, the question is like, rule out is really diarrhea. Then I say like, it's a fecal impaction or incontinence. Then the next thing I do is any medication. So make sure they're not on laxative because, you'll be wasting a lot of time in the, wherever you are, because if you don't take a good history, use the temporal relationship. And then we do this broad classification we can do, right? Let's say, what are the other ways we can classify? Huh? It's like infectious causes, right? Infectious causes, and that can even divide it into non-invasive and invasive species. Okay, so I'm going to put like non-invasive over here, and then we talk about non-invasive. What is the number one cause of diarrhea in the United States, my friends? Bacteria, wrong.
Rotavirus?
It's a virus, but rotavirus is usually in children.
Oh.
Okay, so what is the virus in the adult?
Norovirus?
Norovirus, very good. Okay, always remember, okay? Don't pick like bacteria as number one. So we'll just say like non-invasive, we'll start the virus. Norovirus, everybody got that? Okay? And there's some other virus, but 50% of this caused by this virus. Okay, now let's talk about like what is the other one? Bacterial. Okay, we say like huge bacterial and bacterial pathogens we need to know. Let's talk about some bacterial pathogens. What are some of the causes?
Staph aureus, Bacillus.
Staph aureus, okay. It's good to know the incubation period in some of them. It's also very important to know the incubation period. So Staph aureus, what else?
Bacillus.
Okay, Staph, Bacillus, what else?
Listeria.
Listeria, okay. Anything else?
Salmonella.
Salmonella is which category belongs to?
Okay.
It's invasive.
Invasive, not invasive. So we can say like, I'll say invasive over here, right?
Doctor, could we have E. coli also?
Very good. Yeah, E. coli. Like what type of E. coli? It's like several classifications. Somebody tell me like what type of E. coli causes invasive and what is non-invasive.
Enterotoxigenic is non-invasive. Enteropathogenic is also non-invasive.
Okay. So what is it called? ETEC, right?
Yes.
And what is the other one?
Enteropathogenic.
ABEC.
Okay, enteropathogenic. Okay, so those are the things. What about invasive also, the other E. coli? What type of E. coli appear?
Enterohemorrhagic.
Enterohemorrhagic and enterohemorrhagic. We just put hemorrhagic, right? And then you already said like the salmonella. Invasive, right? Shigella. And then what else? C. diff, very, very common in the United States now, right? Very scary thing is people have like, what do we need to suspect in C. diff? What do we need to ask the patient? Antibiotic use, previous antibiotic, previous hospitalization, very good. Those kind of things you need to kind of ask. So going back to bacteria, what else? Like we talk about E. coli, should we talk about Vibrio cholera?
Yes.
Vibrio, right? Very, very important. You don't want to miss Vibrio. What else?
Clostridium.
Clostridium perfringens. Okay, got it. C. perfringens. Okay, my friend. What else? Anything else we missed?
Invasive is caused by Vibrio parahemolyticus.
Vibrio, that is like a Vibrio parahemolyticus, very good, an important parahemolyticus. Okay? So we covered a lot of things. Just kind of remember, I think, some of the like board questions can ask, but diarrhea is like huge. Okay, you need to know a lot of differential diagnoses, even the acute diarrhea. That's why we went through. So some of the questions you need to know. Remember, you need to express in numbers. So if you look at the staph 4 years, anybody know how long is their like incubation period? It's usually around 6 hours. Remember that. Staph 4 years, 6 hours. Okay, and then bacillus. Anybody know? Say put like 6 hours the incubation period.
1 to 4 hours.
Okay, let's say 4 hours bacillus. Okay, some of them you need to know, and how long is their incubation. E. coli could be up to 10 hours. Okay, E. coli could be like something to remember. It's always good to know, like when they have the infection, how long is the infection. Some of them could be like a very long. Okay, so when you talk about non-invasive, then also you have to talk about the protozoal, right?
Yes.
What are the protozoal we need to worry?
Entamoeba histolytica.
Entamoeba. Remember, entamoeba can stay in the system for a very long time, right? Can sometimes for like, because what? What? Huh? The cysts, right? Yeah, they can stay in the system for a very long time. What else are the protozoa?
Giardia.
Giardia. Very good. Okay, Giardia. What else?
Cryptosporidium.
Cryptosporidium.
Cyclospora.
Cyclospora. Okay, so we got a lot of differential diagnosis, right? So I mean, so remember remember a little bit of like, associate. The other question asks like, what type of population listeria? If I'm writing an examination question, what do I write about listeria?
Pregnant women.
Pregnant females, okay? If I may write diarrhea in a pregnant female, they will write about listeria, okay? And then we have to know, like, staph aureus is associated with what type of food? Just kind of briefly, that's like a huge differential we talk about. Mayonnaise, then meat product. If I have to say like meat or poultry product, just meat, like I think the studies are like 40% of them is like meat, okay? And bacillus, everybody know that, rice? Everybody know that, right? I think people always kind of remember and all those kind of things. And then we talk about the non-invasive, we talk about the virus, right? We talk about the bacteria, we talk about the protozoal, the invasive, we got Salmonella, Shigella, C. diff, and Vibrio parahemolyticus, okay. And which one have the highest mortality in this group? Anybody can tell me? No, apparently Shigella. Okay, that could really, there are some studies have shown, if there is an infection with Shigella, that could patient usually die. Compared to like all the other things, okay? So, let's go into the past medical history, right?
Patient's past medical history has, the patient has diabetes.
Okay, why is that important?
Medication history.
Okay, we already said like metformin can cause. Diarrhea, diabetes itself kind of, what do they do? Like, all this, autonomic function and all that kind of messed up that can cause like itself can diarrhea and abdominal pains kind of symptoms, right? But again, metformin, most of them, they'll be careful about that. Any other past medical history significant in this patient? Hypertension. Okay. Any allergies?
No significant.
None. And then family history?
Not significant.
None. Okay. Still, like, I always remember the point, the H&P, don't take shortcuts. I don't like that. When somebody presented, I need to know. It doesn't matter, even if the patient comes with a scratch, I get all the history because it may be useful kind of later on. I get really upset when somebody presented, they don't take the family history, they don't take the social history kind of things like that, okay? So family history, medications, what medicine is on?
The patient is on.
Always remember, like, people always miss if they're on laxatives. Okay, you have to get that history. A lot of people are like constipated now this day. So make sure the patient is he on any laxative? That's the question.
No.
What are the other medication he's on?
He's on Ozempic.
Okay.
He's on lisinopril,
Okay.
albuterol, and simvastatin.
Simvastatin. So which diabetic medication? Spell it for me.
Ozempic.
Ozempic. Ozempic.
Okay. So treating diabetes, he's on lisinopril, albuterol, simvastatin. What else? That's it?
Yes.
Okay, so we know he's on diabetic medication. Why should we worry about lisinopril in this patient? Because diarrhea, I'd be like very careful, right? They can cause renal failure. So just like when this patient has diarrhea, just make sure you don't want to put the kidney more damage. Okay? So remember all that. So we talk about the medication, social history. Why should we know? What is the social history?
The patient is a smoker.
Smoker.
And he also drinks alcohol, 1 beer per day.
Okay, alcohol. Which diarrhea is very common in alcoholic, which should be kind of deadly? Like, cirrhosis patient, right? Which one? Vibrio parahemolyticus. Okay, that's another board question. Okay, so he's taking alcohol. If somebody have like cirrhosis, if I'm writing an examination question, because Vibrio parahemolytic is common in that group, that can kill people. Okay, examination wise, so very, even good clinical knowledge, we need to know that. If you don't remember that. Sexual history is important.
Yeah.
Why is that? Diarrhea.
Maybe no compromise.
Immunocompromised, right? Any immunocompromised, diarrhea, bad news, right? HIV, right? What kind of things we have to when you talk about, don't say HIV. What is the most important thing we need to know about? Which organism can cause? Cryptosporidium and CMV and all of that is kind of common. Everybody know that. But don't just assume it's just HIV is he got this diarrhea, right? What's the first thing you do? And somebody say this patient has HIV. What's my next question?
Cd4 count.
Cd4 count, okay. So most of these people, they are great drugs now, right? If the Cd4 count is like less than 200, those are the opportunities. So if somebody writing an examination question, there's an opportunistic organism and the CD4 is called like 500, don't pick HIV. Remember that? It's a very excellent point, right? Remember, if it is CD4 is counted like less than 200 or 500 or 100, then I know maybe then I have to. Otherwise, people have a tendency to, HIV, okay, all of a sudden immunocompromised. But most people are treated well, always ask for the CD4 count. Very good. Psychiatric history, why do we need to know about the diarrhea?
Depression, maybe on SSRI.
What is called a fictitious diarrhea, right? People kind of fake all kind of things saying I got diarrhea all the time. Also we need to. SSRI also. I would say like fictitious. I talk about SSRI causing diarrhea. Okay, I don't think this patient is not taking any SSRI, right? So we have all this and tell me the vital signs on this patient, please.
Patient's blood pressure is 139/89. Temperature was 97.9. Pulse was 106. Respiratory rate was 20. And saturation was 95%.
Okay. So we know, what do we know? There's a little bit tachycardia. What are we looking for? The patient is what? Dehydrated, right? That's the main thing. And also we need to know there's a fever. It's good to know, when you talk about diarrhea, what is relative bradycardia? Somebody tell me, anybody know what's relative bradycardia? Relative bradycardia is every time your temperature 1 degree goes up, your heart rate should go up at least 10 or 15. But in some diseases, what happens is we're going to talk about the disease before, but if it is 1 degree goes up, the heart rate goes opposite way. That is called a relative bradycardia, okay? Which organism kind of associated with diarrhea and relative bradycardia? Salmonella typhi. Okay, so if I'm writing another question, always remember Salmonella typhi. What's relative bradycardia? It's a good term. Remember, there's other zoonotic diseases and also cause. We'll talk about some other time. There's another topic. So remember, when you look at the vital signs, look for I would also look for relative bradycardia to make sure. But this patient didn't have any fever. That's okay. And the examination, anything normal?
Yes, everything normal.
Everything pretty normal. So the labs. What are the labs?
On CBC,
Yeah.
hemoglobin was 19.
What is it? Hemoglobin?
19.
Hemoglobin was 19. Okay.
WBCs was 17.
17. Okay.
And platelets were 352.
352. Okay. Now we need the BMP, right?
Yes.
Okay. What are they?
Patient sodium was 140. Potassium was 3.8. Chloride was 110. Bicarb was 20. Urea was 18. and creatinine was 1.3.
1.3. Okay. Any other labs we need to know?
We did
Glucose,
glucose also.
Okay, did the glucose, that's fine.
188.
188. Okay, what else is there? What other labs they do?
We also had this neutrophil, absolute neutrophils, which are 14.
Absolute neutrophil is 14. Okay. What else? Any other labs are
We
there?
did urine analysis as well.
Okay. I don't even know why they did urine analysis, but let's see what's going on in the urine analysis.
The appearance was cloudy.
Yep.
Color was amber,
Okay.
and it was negative for glucose, blood, and ketones. But WBCs were 8 to 10.
WBC 8 to 10. Okay. Did they do any other investigation or anything? Any other lab would have been kind of useful to this patient? Anybody? I mean, I would have checked lactic acid. Okay, it's reasonable. Somebody with any kind of abdomen. He got a white count elevated also. It's like, I would check lactic acid, remember that. I don't know if I'm not so sure they did check lactic acid. What other investigation did they do? They do any kind of imaging?
Yes, we did CT abdomen.
Okay, what did that show?
On CT, we had the findings of suggested for enterocolitis.
Enterocolitis, right?
Yes.
All right, so we have like a lot of labs up here, right? So just circle the labs. We know there is what? There is white count elevated, right? So we need to be very careful. What is this? What is this? Hemoglobin 19, right? Why is hemoglobin is 19 in this patient? Dehydration, most likely. That's like a pretty high, dehydration right here. And then what is this? Bicarbonate. Is it important to us? There's like some metabolic acidosis, right? And maybe why is that? There could be, serious thing is like you can have like intestinal ischemia, right? Which will come back to that. So all of this I'll circle to make sure like I'm not missing anything. So I can learn from here, right? Then I see this also, right? So I know blood sugar is high. All of them I will circle, right? I know this enterocolitis there, right? Let's look at our assessment plan and finish this case. So what is our assessment and plan? Somebody tell me, what do I write? Assessment and plan. What is my number one diagnosis? Can I write enterocolitis?
Yeah.
Right? I would say still write enterocolitis. The CT scan supported, right?
Yes.
And then what would I say? WBC count is what?
17.
17, right? 17,000 WBC. And then what do I do in this case? What is my next step? Do I do like any stool studies? Current recommendation is like, patient doesn't like, don't do like, different, like a lot of stool studies and all those kind of tests, fancy stuff. Why should we do in this case? Age is very important. Even his age greater than 65. How old is this person?
65.
65. So let's, we need to I would just some stool studies. Okay. And then what else? I will do blood culture. Okay, and then I check lactic acid because it was not checked. And if it,
Can we do stool culture?
yeah, stool studies, stool culture also to make sure we don't miss anything because there is colitis kind of going on. And it's okay to start some antibiotic. It's controversial, but I'm will just be on the safe side. Okay, usually what I do is like I would start some antibiotic in this patient. What do we need? Like it's an enteric pathogen. I need to cover for gram negative and like what anaerobes and all those kind of thing, right? So I'll start on like a ceftriaxone plus flagyl. You agree with that? Just like an empiric coverage, okay? And what happens, I just watch the patient. Within 24 hours, everything come back normal. I can discontinue. Because a lot of times what happens, if I don't act on it, if patient die, there's no way I can go back on it, okay? But even if you don't start on it, I'm okay with it too. You can in this patient, but again, there's 17,000. That's my preference right there. Somebody with 17,000 white count, I would take that. Anything else we should do? Do we need to consult? Do we need to consult ID? Because we don't have a question. We have a lot of studies kind of coming. We don't have an actual question. Like we should be a supportive treatment. I would just make sure like IV fluids, right? And I would stop. What is this patient on? I said lisinopril, right? So I would hold the lisinopril at this point, right? You guys agree with that? Anything else we should be doing in this patient? No, right? It's okay. And then let's look at them. I mean, remember, we circled a lot of things, right? We already said like the leukocytosis. We have an explanation because we put it right here. If you want to combine all that, what is the next thing? If there is like, let's say, increased hemoglobin, you can write, right? I'll still write it down, even though it's kind of like, nobody's going to say, I said, what is it, hemoconcentration? Okay, hemoconcentration I will write. And then I can write, what is the next thing? Metabolic acidosis, right? Metabolic acidosis. And what is the first thing when somebody comes metabolic acidosis? What's the first thing we do?
Check the anion gap.
Yeah, it is like anion gap or non-anion gap. So is this anion gap or non-anion gap? Okay, so we get calculated what? 140 minus 120 plus 110, 130. So it's probably like hyperchloremic metabolic acidosis, right? Now we know this is a non-anion gap metabolic acidosis, right? So I'll just say, I will write it down, it's a non-anion gap metabolic acidosis. Then somebody tell me what are the causes, tell me what some causes of the non-anion gap metabolic acidosis, whatever I told you in this. Let's see what the smart people in here. Which one is easy?
Diarrhea.
Diarrhea. Everybody know diarrhea causes non-anion gap metabolic cause. What else? Somebody tell me.
Renal tubular acidosis.
Renal tubular acidosis in what condition? What's the past medical history on this patient? Diabetes, right? Renal tubular, type 4 renal tubular acidosis is very common in this patient. So if I'm writing a question about non-anion gap metabolic acidosis, I would always kind of put diabetes picture, renal tubular acidosis, and metabolic acidosis, non-anion gap. Remember that, okay? And a lot of other things can cause it, which we're not going to, but kind of related to this, okay? And then we talk about WBC. There's a UTI, right?
Yes.
Okay, we don't know. Like patient, I don't know. We can say it's urinary. I would say, what is the term? I would asymptomatic bacteriuria.
Yes.
Okay, we can say asymptomatic bacteriuria. Okay, rather than kind of calling it in a UTI at this point, he didn't have any urinary symptoms, so right? They did not have urinary urgency or anything. So what do we need to treat this patient? That's the question for UTI. Which condition do you treat the patient for urinary tract?
Pregnant patient.
Very good.
Right.
So if let's say if somebody have asymptomatic, don't anything, you just did a urine analysis, come back, urine WBC greater than 5 is UTI. Okay, so the first thing is like the patient is pregnant. If it is pregnant, you treat. What is the other condition? If you're undergoing any kind of procedure, if it's an invasive procedure you're doing, always kind of like, because it can damage the mucosa and those kind of things, you're supposed to give some antibiotic at least an hour before and all that. Okay, in this patient, I just kind of watch it at this point because I'm not doing anything, and we will. Everybody agree with this plan of care?
Can
Okay.
we go with infectious consult, Dr. Cheriyath?
What is our question to infectious consult? Every time before I consult, I will ask 2 questions, right? Don't get in the habit of I've seen these people. Enterocolitis, consult ID, the first thing, I get really mad. If you're on my service, you're fired, okay? Because God has given you a brain. So think about it first, right? Who's smarter? You are the smartest person, not the infectious disease doctor. We always remember that, okay? That's why you do your H&P, you do your studies, and you come up, and then you don't understand, and you have a question, and you say an infectious disease doctor, I did all these studies work up. And then I have a particular question, what causing, I'm not so sure, and all that. Always remember that. Thank you so much for watching. We'll be back with another presentation. Please put if you have some comments about the management, or you think we should have looked at a different way, put it under comments, and so we can have a very good discussion so we both can learn. Okay? Thank you so much again. Please subscribe to our channel. It will be very, very helpful. Thank you again. Thank you.